everyone. Welcome back to A Perspectives. I am Martina, and we have my wonderful co-host Lisette, and we are back part two with Carmen. Really just picking her brain. We're learning a lot of new stuff. If you have not watched part one, please go back and watch it. It's really good, and it's things that all of us on this video right now are all in different sectors of healthcare, and it really has been like shocking a little bit to me and Lisette to hear some of the things that we were talking with Carmen about in the last video. And this video is also going to be good. So go back and listen to that one or watch it or do both. But yeah, I think, we're just going to continue the conversation. Lisette, where did we, because I know you were making notes.
Well, I know that we ended sort of around a phrase that Carmen said, patient-centered care and
Yes.
what it means. And I think it's talking about like in the ideal world what it would look like. And I think we were kind of more talking, maybe explain like what does it really look like and what are really the barriers to that. And I think maybe that'll just be a great way to kind of kick off this part two, to just kind of go from that lens of, I really want to hear like what ideally is patient-centered care, Carmen. Like what is, like, if you were like, this is sort of the perfect scenario of what it should be and what it looks like. I'd love to start there, and then we can come back to the reality of what it looks like. What does it look like from like your perspective?
Well, I think patient-centered care is continuously evolving. I think right now we're in a place where we are leveraging technology to help enhance patient-centered care. And I think with the pandemic, a lot of places have transitioned to telemedicine, which has been super useful to certain people. And I think that that's something where, yes, it's patient-centered for certain people, although it doesn't really give you the same effect for others, because there's a lot of, the technology gap is there. There are language barriers, there are device, inequities, there's broadband inequities. So all of that plays into the situation. But I think ideally, the concept is that you're providing care with patients engaged in the care that you're providing, and that you're being cognizant of where the patient is and you're really meeting them where they are. And it could also be, through the lifespan. So the patient-centered care for a pediatric patient who's under the age of 10 is different from an adolescent patient, is different from, an adult, a young adult. And so, as someone ages, that also continues to change, where you might see somebody who is aging might need more services and more, tailored, services to them. And a good example is as somebody is aging, they do need more services, for just kind of like normal, natural reasons. And it strikes me that both of you mentioned working with your parents to help them navigate the system. And so I think in an ideal world, the healthcare system would have those navigators who are reimbursable to help guide the patient throughout that care. Right now, of course, these are our parents and we love, helping our parents, but you are doing work that, to me, I think the healthcare system could be helping with. If we had more community health workers, if we had navigators. But the challenge is really difficult when, for example, if you have a language barrier, and at our FQHC, 98% of our staff, who are front, patient-facing staff, they speak Spanish. But once they're outside our walls, patients, we don't have that control anymore, and they might have to go see a cardiologist or a neurologist or dermatologist who doesn't speak the language. And then when you look at, the language is so important to be able to engage in meaningful dialogue and to be able to understand what the care plan is. But oftentimes, patients are looking for somebody to accompany them to those visits so that they feel I know how to navigate this big giant building that I'm being sent to. I am not going to get lost. I'm going to not have language barriers. I have somebody who can join me in that process. And I think that's something that the Affordable Care Act through Obamacare intended to try to do, back in 2014, but it didn't quite work out the way we needed it to, because there's just so much coordination of care that's necessary. Even the referral system, being able to have a patient make an appointment with a specialist outside of the primary care system is super hard. I myself have a hard time. I have to go see my dermatologist and had to wait forever to get an appointment. And when I initially attempted myself, I was told that it was a 1 year wait for me to go see a dermatologist. And I'm like, I have urticaria. I'm like, I can't possibly wait a whole year to see a dermatologist. But I was able to fight back because I have, I'm empowered to fight back. And I'm like, that's unacceptable. I need something way sooner. But a patient who doesn't know that they can fight back, they're might suffer for a whole year because that's the soonest appointment that they were given. And so you really need somebody to help with those the referral process. And then the other piece that I think was a bit of a miss with electronic medical records is that they just don't talk to each other enough. They do a little bit of communicating, but it's not enough. So when the patient finally gets to the specialist and the specialist sees them, the patients can't always really share why they're there. They might know here and there, but the specialist is like, I need more information to really make the most out of this visit. And so if there was better communication with electronic medical records, they would also be able to see why the primary care provider sent the patients in the first place. And then they would be able to send the results of that consultation back to the primary care provider. But instead, it doesn't really work that way. We're still faxing things, we're still mailing things, and it's just so antiquated. And that could have and should have been a resolution of electronic medical records. And that in and of itself, it's its own business, like EMR systems, because they're very expensive, they're very competitive, and they build them in a way so that they could sell it to more entities, like different entities. So to the physical therapy system, to the dental system. So that's their incentive to be able to market their platform to different health entities. And so it just doesn't line up the way it's supposed to. And that's why you need all of this extra, you have all of these extra resources placed in, but it's all still continues to be fragmented. So that patient-centered approach really falls short because you just don't have the right systems in place. There's too many systems to like wrap your hands around to really make it work. And so I think the concept is very idealistic. Like, I think it would be great if we could make patient-centered care work. It's just incredibly, incredibly challenging to do.
One of the things that I was talking to Martina when we were off screen before we started recording was sort of like, I've been around in spaces where they're like, hey, like, in order to create that sort of patient-centered care and understand more of the patient needs, like we can just have, do a food insecurity screening, or we can have a social determinants of health screening. And, kind of thinking, if you have, like, again, if you haven't seen part one, this will kind of resonate. If you have, like, to understand, like, well, who's going to do the, that screening when you're kind of limited on time to see the patient.
Mm-hmm.
Your nurse is not being reimbursed. You have people who are doing care coordination, but they're not reimbursed, and you're kind of wanting to take, which you in your head, if you're not the one doing it, could take you, you're like, oh, it's just a 5-minute, questionnaire. But if I know my people, they're gonna be talking to you and like telling you. Like, I'm the same way. You start asking me, personal questions, and you're kind of digging into what's around me, and that's what, a social determinants of health, a good social determinants of health screening that kind of identifies what are your needs outside of the medical and sort of thing. A good one will kind of dig into that and for you to understand. But I was like, that's another maybe 15 minutes with a person that you're not even getting paid for. You're not getting, there's nowhere for you to be reimbursed for that. If depending on who's giving it, like, and things like that, like who's, because the provider most likely will not be the one wanting to do a screening.
Yeah.
If I'm being honest, from what I've just, from my interaction with the healthcare system and those, so it's like, so it's just very, like, I think it's, like, but your thoughts around there, like, because I know that some FQHCs have incorporated them. They've incorporated them maybe with like fewer questions and things like that, but like, how does that play into sort of that, it's a need, right, for that patient-centered care because you want to know, but how do you keep it ongoing when maybe you're not being reimbursed for it?
It's really hard. It's really hard, and we get requests from everywhere. So all the different societies will say you should be doing this type of screening to just make sure that you're providing the best preventive care possible. And we know this, like, we know we should be doing more screenings. We know we should be catching more stuff. It's about two things though. It's about like who's going to do it and during what time, and then what are we going to do when patients screen positive. We really want to make sure that we have then something actionable. If somebody says like, yes, you just asked me about domestic violence, and yes, I do have, there is intimate partner violence in my home. And so now what? So we need to be able to take action on that. So we always try to be really thoughtful about what we're asking and what like can of worms are going to be opened up from these conversations that we're having, because we know that it's happening. And so we just need to make sure that then we know how to take action. And I think what we try to balance is what are the things that we absolutely have to do that are like non-negotiable that we incorporate into a visit, and then what are some of the things where we know, from data that is affecting our community. So for example, right now, we really have concerns of the violence that's happening in our communities. And when we look at adolescent care, we are doing the type of visits where we do what's called the heads interview, where we ask the parent to step out of the room, and then the pediatrician has one-on-one time with the adolescent to really dig into questions about like sexual activity, about depression. And so that also takes time. You have to develop rapport with an adolescent for them to be able to share with you what might be happening. And for us, we actually think that that interview doesn't go far enough. Like, we also feel that we should be asking about violence in the home, violence in the schools, guns in the home, because we think that all of that does affect, our communities probably more so than others. But that's something that maybe hasn't come down from the top that you absolutely have to do. So we also try to figure out what are some things that haven't come down that we should be incorporating because it's important to the communities that we serve. So I think we really try to make sure that we're balancing that and making sure that we are taking care of like the most important items, and that we're also following up closely, because we might not get to everything during the first visit, but during the follow-up visit, we want to enhance what we did during the first visit. But then you start to also, that access to care, if you are seeing somebody 3, 4, 6 times a year, then your visit slots start to get booked. So then your panel of patients, begins to be smaller. So you don't have the opportunity to see newer patients, because your panel of patients are already taking, all of your slots are essentially spoken for the provider. So we really try to balance that, but it's hard, it's tricky. And then we try to also be, that continuity of care is also part of patient-centered care, because if a patient sees a new provider at every visit, that they have to establish that rapport. They have to go through the whole medical history again. And so we really like to encourage patients to find a primary care provider who we really mesh with, who we really like, so that they could build that history. So when they come in for a follow-up visit, they know where to pick up versus having to start all over again, which is a problem, can be a problem if you change your insurances every year for whatever reason, or if you get bounced to a different managed care organization. So it hasn't really happened during COVID, but pre-COVID, you have managed care organizations that sort of like lure patients to like their plan, and then that might mean that they now have to change primary care providers someplace else. So there's luckily during the pandemic hasn't really been happening, but just like all the things that really affect your ability to provide patient-centered care.
Yeah, I don't know if you have any thoughts. I know I've been dominating.
I just, mine was really, I think I had another question for kind of a different topic. So Lisette, jump in if you have something. Yeah.
No, I think one of the things that when we think about health in America and more of like the status of it and the inequities that exist is not understanding what healthcare, what it all encompasses, right? Like when you were, bringing up, just for me, is like, because I delve a lot in the social determinants of health, that's one thing. But when you think about violence, and particularly when you live in a city like Chicago, where violence is all around you and then sort of continual, and there's different kinds of violence. So it's not just the violence that you hear in the news, but there's the violence that you just maybe experience at home and things like that. And to kind of like, I don't always equate it to healthcare, but it is part of it, and it is there. And to think about how, because of the inequities that exist in our systems, how hard it is to really help people, right? To really kind of help them, to really provide the services that they need, whether, it's just, a Band-Aid or a mental health, crisis, and providing that sort of thing. Because I think that falls into that. And it just, to me, showcases how fragmented our system is when it comes to healthcare, and how hard it is for not just the patient side of things, so not just the individual that's seeking, but how hard it is for those that are in the healthcare field, that are the professionals that want to help the patient. Because I've seen doctors and nurses that want to help you, but they can't because they are limited by the system. So it's just, to me, again, it's insane and crazy to kind of understand that, but also like, but yeah, I think that's sort of what I was just thinking as you were talking about, like how fragmented, and I know you all, like as far as the health center that you're at, like I know you all and how much you care about the community, you want to help, but to hear more of like there are barriers to what you can do, because it's just the way the system is not set up in a way to help our communities. It's saddening. Like it's saddening. It makes me upset, and I'm like, just break it all out, just dismantle it all, and let's start from
build it back up again. Because Carmen, you touched on the violence, the domestic violence, and it's this can go different ways, but it's like, so you do that screening, and someone is living in a household where they are being abused on a daily basis, or you do one around a food insecurity, and the child doesn't have adequate food to eat. Like, what do you do? What is that next step? Because that child's going to go right back into that home, and the person being abused is going to leave that, leave the clinic and go right back home again. And it's like, healthcare is not, it's like we will ask you the questions, but we won't, where's the follow-up? Where's the follow-through? Because of all this fragmented things that we have, it's like, how do you adequately get people the help they need in a timely manner? Because to me, I would think if somebody, if they just did this screening, this person doesn't have any food, next thing I would think, okay, well, we have this organization that we work with, they can get you food today, but it doesn't always work out like that. Sometimes you have to go to different processes. You may have to be on a wait list in order to get food, because there are so many people going through the same situation. So it is true, with Lisette just saying, just tear it all down and just do it all over again. Although we know that is much, much easier said than done, because this we were talking about with the health records, it's hard. It's not just like you can stop all these systems that we have in place. And so I think for me, that's really, you know, kind of maybe turning the conversation a little bit, but how we've been talking about this transformation of care, and how the patient is the center of it, and they need to be the center of it, and really just got me thinking, you know, how do we do that? Where do we start? You know, I know that, again, that's a very broad question. And
Carmen has the answer. No, she doesn't.
You know, I think we know the answer, but you know, how do we implement it? Like, you know, how do we do it? And just, you know, again, like I think talking about the electronic health records, why is that so hard? Why is it so hard for sometimes clinics and doctors to talk to each other? Like, I get it, they're busy, but some of this business is set up to be orchestrated because of the systems that we're in. But it's like, why is it so difficult to connect these health records? You know, I know there's a lot of private information, but there's a lot of also the business side of things, as we've been talking about, because we do have these organizations out here selling certain things to different clinics, and they don't want to talk to this organization and vice versa. I'm like, where do we start with that? Because to me, like, that's something that I'd be like, hey, both of us have the same patient. Let's just see, you know, it's like, I don't know, it just seemed like I can see, like, to me, it just can seem so simple, but it's not. It's not simple to do. It is very hard to do. Yeah.
Yeah, well, I definitely don't have the answers. Aside from saying, let's just blow it all up and let's start all over again.
Right.
But I think, yeah, there would be so many forces against that. Like the EMR system, that's a whole industry in and of itself. And so they have just grown into like this, you know, mammoth. And I think I don't know. There's this like, we don't talk to each other. Like, this is going to affect, you know, my business capacity if we, you know, change things. And so you need almost like the policy end to step in and say, this needs to be universal. And I think it also aligns with something from a couple of episodes ago where you were both discussing and questioning, why is healthcare tied to your employment? And I think healthcare is tied to two things. It's tied to employment and it's tied to poverty. So if you are employed, well, because healthcare insurance really came from only the people who work, who go out of the home to work, are privileged enough to have healthcare, because we need to make sure they're healthy because they're out in the workforce. So that really left out women, you know, because, you know, at the time it was mostly men who were going out to work. And then, you know, children, like healthcare was seen as a privilege only for some, for those who were, you know, earning. And that's never changed. I don't understand why that's the case. Why our car insurance and home insurance isn't tied to our employer? Why is our health insurance tied to our employer? That doesn't make any sense to me. And then on the other side, you have the other way that people can get insurance is they're either employed or they're living in such poverty that they qualify to have, you know, state, you know, federal sponsored insurance. So those are like the two qualifiers to have health insurance. And it just seems like that's a problem, you know, in and of itself, that I think it really eliminates some people from being able to, you know, get and stay healthy. And I think there's just so many different like facets that really need to be talking in order to kind of work together to come to this universal place where everyone should have insurance. And our systems should flow freely. Like, we shouldn't even have such a system where insurance determines whether or not you need specialty care. A primary care provider should be the one with the patient having that conversation and deciding, yes, I need this advanced level of care now. But it shouldn't be the payer who says, let me take a look at your chart based on those signs and symptoms. Yes, I'm going to go ahead and like, you know, flag you through. Like, that's not how it should work. Like, what do they know about what symptoms a patient is having?
Oh, yeah.
Yes, to everything you said, Carmen.
Yes.
Yeah.
Like, especially the policy. The policy is one we do always talk about. Yeah.
And one thing you brought up sort of, and I don't think I equated in around being so poor that you qualify for healthcare. That's the only other way, like the only other sort of way. And you have this middle section that doesn't qualify because they're not poor enough.
Mhm.
And then they may be working in places where they don't offer health
Mhm.
insurance, and they're still part of, or they just, don't have a job and all these things. And it's this spectrum of like, if you're employed and you are fortunate to be employed in a place that offers you,
Mhm.
full benefits and your insurance, and also like, is their insurance good? Because then you have,
Mhm.
and can you afford to pay for the good insurance if you are employed? Like, can you afford to take the bigger pay because you're going to get, whether it's PPO and all those things that cover everything, you don't have to worry about referrals and things like that. That's a
Mhm.
whole other thing. But the thing that caught me is sort of being so poor that you know, qualify for, your state kind of health insurance. And I'm thinking of like just in the city of Chicago, who those people are. And it's mostly Black and brown communities here in Chicago who will most likely qualify for that. And I'm thinking of like where historically, where did that like, how does that even come into play? When I think, like, I'm thinking of Medicaid, and
Mhm.
sort of what, does race play into that system? Like, how does that, from your point of view, does that, like, is there like, is it a racist system? Is it something that, it does race play into it? Like, is that part
Mhm.
of the problem when you think of something like Medicaid?
I mean, I think so, because when you see who the, like you said, the beneficiaries are
Mhm.
in Chicago, like, let's not even looking at like nationally, but in Chicago, you see who is eligible for Medicaid, who is eligible for WIC, who is eligible for TANF. It's like the same folks who are eligible for these systems. And so then they get like locked in to, this eligibility criteria. And then where they get to go for care also has, like, there's a pool that they swim in. Like, these are where you can go and get that care. So sometimes where they can go to get care are systems that are strained because there is like an overfilling of that pool into those systems. So the ability to receive that higher quality care is then affected because you have so many people swimming in that system. And so you start to see like the quality of care just not up to par at places where they're not as overbooked with patients. And so the access to care is, 3 months away versus it could be, next day or even same day in some cases at other places. So you see delays in care start to happen. And with chronic conditions, if you delay care, you are going to be in that like uncontrolled status where you might have more consequences, where now you're going to need more medication, you're going to need more follow-up, and that hill to get better is such a higher climb. But it's because of what you have to work with. Like, you were sort of told, this is the bucket that you belong in based on the situation that you're in. But we know that people are in situations because of structural racism. And so that is like where things start to, like, where the root is, like the root cause of so many of these issues. And it's just really hard to, when you start to think about and reflect on how the whole system is generated. Like, it definitely is. I mean, it is a structural racist system.
To me, it almost seems like, and government and policies are doing nothing about that. That is the issue that we're up against. And it's almost like, there are a lot of grassroots organizations who are trying to help and do this work. But at the same time, you need something happening at this top level, and we need to meet. And it almost seems like we don't have anything that's happening at like the state or the federal level that's really going to change these systems. And I think it was one of you that said it's just a band-aid at times to, just get somebody fixed up and get them out the door, if you can even get them in the door. And it just seems to me like there's just this imbalance of where we need real change to come from. I don't see it. That's just me. I feel like I don't see it happening from like a state, federal government level, but you do see it a lot at grassroots in the communities, because communities, you know, really do care about this, and they really do care about the people that live in their communities. We definitely all see that. But at this federal, at this top level, you know, again, it's just, you know, they'll put out a policy. Okay, so if we actually get a good policy, how do we get it implemented? How do we make sure that it's sustainable? It's like there's no follow-up. So how do we know that people are actually getting the care that they need in an adequate amount of time? That was a very broad statement, but that's just one of my takeaways from that.
And I think you bring up such a good point when you think about why it's not happening, and you look at sort of the capitalistic view of this country, you know, and you go back to that sense of like healthcare is a business, and who is more interested in continuing it to be that way and not change it. You know, you're looking at those that are making money out of it, right? Those that are, you know, getting the millions of dollars out of our current healthcare system, and who have the funds to lobby against any changes, right? Like you think about, go back to like when, you know, the Affordable Care Act came out, right? And so like it was meant to be one thing, and by the end it was something so like very little like help. Like it was like, I don't think this is what Obama had set out to do, but because there's so much money thrown behind those that are interested in keeping our healthcare system the way it is, and not allowing for that, you know, whether you call it universal healthcare, whether you call it, you know, that, like not allowing, you know, things to be how they're supposed to be, to allow people to, for everyone to, like, I 100% think that healthcare is a right and not a privilege. Like I think everyone deserves to have access to good quality healthcare when they need it, whenever they need it. Like you know, it should be there for everyone, and we all should have access to it regardless of how much money you make, regardless of, you know, all those things that are currently in place. Like, you know, health insurance to me shouldn't sort of exist in sort of a in the way that it exists here in the US, but there's just so many big lobbyists out there that are funded by, you know, whether it's insurance companies, whether it's others who just have a vested interest, whether it's those that have, you know, the EMR systems, right? The electronic medical records, who are like, no, if you all start talking to each other, someone's gonna lose out, right? Someone's gonna lose out in this game, and it ain't gonna be me. Like it's not, and it's placing money above just humanity, right? Like human care and the caring of your fellow people. And I think that's, to me, why I don't see it happening. I think there are policies that are sort of put out there that, you know, legislation that's like, yeah, let's try to do it, but by the end it causes very little impact in the change. It's sort of like, we tried, here's what we could, you know, do. Good luck with maybe in a few years be able to do something different.
It's
You know,
almost like you're just doing it to say that I did something, I tried, that's it.
And I think the insurance companies also have some type of like hold on the consumer as well, because I was pretty taken aback during COVID when, you know, insurance companies were told you had to pay for COVID tests, you had to pay for COVID vaccines. And I was kind of taken aback by patients who would say to us, like, why are you asking for our insurance information? This is supposed to be free. And they almost didn't want to give their insurance information because they see that as an association with then their premiums going up at some point. And they were almost like defending the insurance companies, like, this is supposed to be free from the government. And I remember thinking, like, this is definitely free for you. It's free for you. The government is giving us the vaccines, but we have to pay for the people who are giving you the vaccine. You know, we have to pay for that staff member, for the nurse, for the medical assistant, for the supplies that are associated with booking the appointments, for the space that we're using to get you vaccinated. All of that is an additional cost that we that we have, and that insurances, they should be paying for them. Like this is going to be free for you, but the insurance needs to pay for the costs associated with keeping you healthy. And they do have an incentive because they're not trying to pay those COVID hospital bills. They'd rather pay for a vaccine, in a heartbeat. It's like why they happily pay for a flu shot, because they also don't want you to be in the hospital for that reason. But I did think that the insurance companies were nowhere near vocal enough to tell the patients that this is going to be we got this, like we're covering this, and I think that they really should have done that, because otherwise we had patients defending. They're like, no, why does my insurance have to pay for this, or why do they have to pay for this test? And it's like, because they have to, like they're the ones who you're paying, and
that's why you have insurance.
Right.
Yeah, and we were sort of the bad guys, like we were sort of seen as the bad ones there for trying to recoup the staffing costs and trying to recoup the space costs, of having like mass vaccination sites. So it was just really an interesting dynamic to just see play out, and just like the perception of what insurance is intended to do and the consequences of actually using your insurance. So similar to like if you're in a vehicle accident and you submit a claim, like your insurance goes up, that's sort of the perception the same, when it's really just the insurance companies making sure that their profits are not eroded through this new service. But the companies, they had saved so much when COVID first started, because they weren't doing elective surgeries, because people weren't going in for mammograms. All of that was, in helping their bottom line when all of those services stopped. And so anyway, I really felt like telling our patients, like, please don't feel sorry for them. They're okay.
Yeah, they'll be fine.
I gladly gave my insurance. Here, bill them.
No, bill them. Let them do their job.
I pay a monthly premium for this purpose.
Exactly. And that's so true. Insurance companies, they made so much money at the beginning of this pandemic. And to me, it's almost, I think talking about having to give your insurance to get that free test, or that free booster shot. To me, again, that kind of comes into like, why isn't our government making sure that these things are covered? Like, why should we have clinics having to come out of their pocket for these things? Like, this is global. This is, something that's affecting all of us. And this is just the pandemic. I mean, even if we were not in a pandemic and still thinking of these things, this is where I feel like government, they are allowing these big pharma or whomever to be able to operate like they do. And also with these huge insurance companies, they're just being allowed to operate this way. Like nothing is blocking them from treating patients and clinics of the way they are. And there's no one saying like, you shouldn't do this. This is wrong. This is why it's just continuing happening. So it was just interesting to hear that you had patients who actually blaming you all, like, no, I don't want to give you my insurance. It's just, again, to be able to hear that this is actually happening. Like they were almost, please don't feel sorry for them. Don't feel sorry for insurance companies or any of them. They are making loads of money, whether we were in a pandemic or not, but they're making loads of money. That's so fascinating.
And to your point where like, the hold that the insurance company has, because people don't understand insurance.
Yeah.
Right. Like I think I don't know if society, insurance, whoever has made such a good example of people, has done a good job of ensuring people don't know how insurance works.
Yeah.
Like, and how what it's meant to do, how it operates. Because like I have this conversation with anyone, like I know I pay my premiums, I understand sort of my deductibles, I understand. I was like, but there's still things that I'm like, I don't know exactly what they do or how this all works or how it like.
They want you to be confused.
So it's like, so it's a thing of like, they've done such a good job of making it so, either making it seem like it's complicated, maybe it's not complicated, I don't know at this point, but I was like, they made it seem so complicated that people are like, I'll just let it do its thing, I'll get the bill and then whatever. And
right.
whatever happens, happens. Because I think that's usually what people do. They're like, unless it's a huge bill and then you call and you're going through like person to person and you're trying to figure out. But like, it just makes it, I'm not surprised that people were like, no, because they're like, because we have such limited knowledge of how the insurance really works that we're like, no, the government's covering this. Like, that's not, this is, it's not the way. But to hear it like, but it makes sense because we're like, we're not really taught of how it all works at the end of the day.
Yeah, that's true. That makes me kind of giggle, Liz, because I just had I got an explanation of benefits, like a bill. Well, it's an EOB, so it wasn't a bill, but it was from lab tests that I had gotten done, and the bill was 7 cents. That's how much I was being charged, and I remember like, how did we land at 7 cents from here? Like, why did it? Tell me more about how this was what I ended up getting in terms of like my portion of the fee. Like, because now I have to take time out of my day to log onto this portal to pay these 7 cents. Otherwise, they're going to bill me in a month for 14 cents because there's a charge if you don't pay these 7 cents. And so I just didn't understand. Like, I was like, what type of formula or system was in place where the end result was me owing 7 cents for this one lab test?
And why couldn't you just cover the 7 cents? Like,
and you have me be Carmen. I have one because actually I see an allergist, and I had a bill of $3.74 one time. So you beat me with 7 cents. I was like, it was so low that the allergist was like, you know, we'll just wait and add this to your copay. Because they were just like, you don't have, please don't worry about this $3.74. This is not a big thing. It's so 7 cents. Wow.
Yeah. And like, why did you mail this to me? The cost to mail it to me.
How am I getting this?
More.
Yes. You paid more for the stamp.
I did.
Yes.
But like, it's just the thing of like, you know, how really, I think just our society, you know, because I think obviously our government has its own biases and preference of who they're going to support and who they, because they do receive money and all these things. And that's just the reality of our country. And, you know, we can go into the whole two-party system and all those things that kind of encompass all of it. But, you know, it really is such a, it makes me laugh, but it's also like, oh, here we are, another sort of just reason why it's so hard to get that, you know, healthcare for all kind of aspect of it. But I think one of the things that we touched on a little bit was sort of the transformation of healthcare, and you know, and what that kind of, you know, looks like, you know. But you know, to kind of go on that lane, like, what does health equity look like? You know, what is it? Like, what does it entail? Is it, you know, just everyone having healthcare? Is it more than that? Like, from your point of view, Carmen, like, what does health equity look like to you? Like, you know, sort of kind of going down that lane.
Yeah, so I think that equity needs to be baked into our system. Like, I don't think that we need a branch of government that looks at it. I don't think that organizations need to have a senior vice president of equity per se. I think it just needs to be baked into the culture. I think it needs to be baked into the educational programs that we have, because I think it's going to continue to be a predominant factor in the health status of people. And I think that that's really just something that's that should be just kind of part of, you know, how you operate in a healthcare system. I think that there is, I mean, I tend to be an optimist, so I'm hopeful that now, like, this topic has landed. Of course, it took COVID to make it so hyper aware to everyone, but I do think that it's in everyone's mind, and a lot of people are like, shoot, I don't know what to do about this. And I'm okay with that answer, because I'm like, okay, well, at least there is some acknowledgement that this should be addressed, that there is some ignorance behind it that needs to be addressed. And so I'm hopeful that we can continue to have that conversation and look at all of our systems and how we make sure that we're not unintentionally, doing something that's causing harm. And so for telemedicine, I do see the potential to increase access to care through telemed services, because if you have providers who are working telemedicine from home and they're conversing with patients like this, that opens up physical space in the clinics for there to be more providers on site seeing patients who need to be seen on site. So there is the potential to almost at least grow by a third your services if you have people who are off site providing care. Who should be seen through telemedicine and what type of visits, that still is to be designed, because we know that for certain visits telemedicine works well and for others it doesn't. And so we really need to also keep cognizant of making sure that we're not disproportionately allowing those who have access to technology to be disproportionately receiving these convenient systems. So people who have technology, people who have better broadband access, people who have upgraded devices where video works better, and then any language barriers. So even like now, as like you shake your head, I get that you understand like what or that it's landing what I'm saying. But if you have a patient who's only discussing with their provider through phone, they might not see that. So you lose all of those physical cues that you would normally have in a visit. So we don't want to lose that. We want to be really careful with how we move that forward. And I think, so there's definitely opportunity to improve access, for patients who wouldn't typically have access, but we have to be really careful and really thoughtful in the way that we do it. And now you get reimbursed for telehealth services, where right before COVID, it was like unheard of. Like you were never going to get reimbursed for this. So now you see the power of power, where if from one day to the next, yes, all of a sudden telemedicine is reimbursable. So I think that I hope that people do not forget what was able to be accomplished in a short period of time when the will was there. So I really hope that that really affects the quality of care in an equitable way for patients moving forward. And I'm hopeful that telemedicine systems work for all and not just give convenience to a certain group of people. So I'm going to try to stay focused on what we can do now, and of course share our experiences, both from the provider side, but also from the patient side as well, because I think these stories need to be heard. And we want to make sure that we do everything that we can to create an equitable space for patients.
Thank you for that. I think, and Martina, I want you to think about it, because I'm gonna ask you too. What do you think health equity kind of looks like from your end? These conversations that we've had today. But one of the things that I had mentioned, when we were kind of taking a break in between and off screen, was when you talked at the last episode at part 1, sort of like the nurses not being reimbursed and what that looked like. And I had a moment where I was like, who developed these systems, right? There were white males who developed these systems, who developed these things, and you kind of see that, the white supremacy that kind of infiltrates so much of a lot of our systems, and understanding that, because nursing was probably a field that for the longest time was women, and in women's value is not really seen as that. So I think when I kind of, at least for the moment, because I agree with everything you said around health equity and what it means, I think is really kind of understanding how these systems were created, how they were sort of set in place, and who set them in place. So you're looking from a very white male centric point of view, and sort of systems that really need to be looked at and seen as to like, okay, we understand that because of this white supremacy, because of this white male dominated kind of feel that it was when it began and all these things. And you know, and there were physicians and the hierarchy, right? The hierarchy that exists in a lot of our different industries, and sort of like, here's the value that we place on doctors and physicians, and then this is who we think deserve to be reimbursed and who deserve to get what they get, and all these things, versus, and most of, obviously at the time, mostly they were all male, like that's who was seen. And you know, in a lot of places it's still very male dominated field. And and the nursing kind of realm of it was like, okay, you're women, your value is less, and this is just, you know, whatever, and all these things. I think it's really kind of taking that into consideration when you think about health equity in general, of like understanding sort of those systems and how those things have to change, right? Because now that you see it, now that we see more of these, you know, when you think of like, who are the community health workers, who are your medical assistants, who are your, you know, who are your potential nurses, most of them are going to be people of color, you know, and the inequities and the health equities that exist in that are real. Like, why are we not seeing their value as much as others? And I think that's for me, it's a different side of equity. It's not sort of the patients, more of like the systems, and how do you bring that equity into the systems that will lead to you having better outcomes and better health equity outcomes, because you're gonna have people that reflect, people that are gonna be valued. You know, you have these healthcare professionals that are gonna feel like they're valued by the system. So I think that's just a different kind of sense that I was just kind of thinking about when it comes to equity. But you know, Martina, I'll let you kind of see if you have any thoughts around
Y'all
what
have
equity.
solved the issue. Both of y'all have solved it. We got everything. It's solved. But I think, you know, and not to be long-winded, I definitely do agree with both of you. And I think, as we always say on this channel, is that these systems are created exactly how they're supposed to be. They're benefiting the people that it needs to benefit, or that it was expected to benefit, and everyone else has just gone to the wayside. And so I really think we do have to get to a place here in the United States. And Carmen, I believe you said this about having good healthcare is just a part of the culture. It shouldn't be something that, oh, well, because you have this insurance or you have this amount of money you make, okay, we're able to see you first and get you into the best hospital and get you the best care. No, we should have that for everybody. Why is it so one-sided? It does tie into this white supremacist patriotic way of how the systems run in the United States. And to me, it just, I think we have gotten to a point, again, it took 2020, everything that happened there and everything that's still happening, for like light bulbs to start going off for people. I think for us here, we already knew some of these things, but it took other people to be able to be like, yeah, this is really bad. Like, what is social determinants of health? I want to know more about that. You know, why do we have so much violence in this community? And how does that tie to health? I think it really got people who were not necessarily working in those sectors or even living in those communities or haven't just grew up that way, really started to understand, or at least I think it really opened the door. It opened the door for people to kind of understand some of these issues. And so I just really believe we have to keep opening that door and really just looking at healthcare as like, this is a right. It's not a privilege. It's not something that you should just have because of the color of your skin or your economic status or your educational status. It's something that everyone, to me, before you're born, when you're in the womb, this is something that you should have. This is just a part of life. It's just a cultural way of being, just like everyone should be afforded an education, which is often a different topic too, because everyone doesn't always get the best education. I grew up in Mississippi, so I know how the educational systems work. But it's like, you know, those things to me are just God-given rights, like education, healthcare, food. Like, there's no reason in a country such as the United States where this should still be an issue. Like, we're still talking about these things that we've been talking about for so long. And again, we've gotten better, I think, a little bit at the time, and it's going to take more time because these things did not happen overnight. So we're not going to solve this overnight. But I think the more people we can get to try to really understand, we all in this together. Everybody just wants to have a decent life and everything that comes with that. And so hopefully, you know, I'm going to be optimistic too with Carmen. You know, and I think, you know, eventually, hopefully, we will get there. And I just think if people just can continue to have the hard conversations, because they are hard, these are not fun conversations to sit around and talk about at times. But in order to get the country where we need it to be, we got to continue to have the hard conversations and do the hard work. Like like something has to happen with, for example, electronic health records. Something's going to have to give, you know, in order to make healthcare better. I don't know what it is right now. I don't know when it's coming, but like some things are going to have to change. Like things are going to have to change for us to do and get better. So I'll say that.
So I think we're kind of at a point to wrap up. So Carmen, I just want to give you just a moment to sort of give, you know, sort of your, maybe just like some final thoughts about, you know, the conversation we just had, or just thing, you know, whatever you kind of want to maybe just say, like, oh, I don't want to leave without saying this, or I don't, I kind of just want to close this out. So just, you know, give you a moment to kind of just share a little bit before we kind of just wrap this up.
Yeah, I think I know we covered quite a few topics, but I would probably say that that behind the scenes, folks are really trying hard to try to not let all of these different systems affect the way care is delivered to patients. And if you encounter as a patient a situation that seems a little bit odd, there's probably a reason behind why that's odd. So there's probably a reason why I got that 7 cents bill. And so I think like wondering why this situation happened like this, it's probably like there's a mapping that you could take behind why that certain thing happened. And so I would ask questions like, you know, be curious about like, why can't I get an appointment for 12 months? Why is that I can't give this message to my provider? Or why am I not allowed to see like the nurse more often as I would like to? I think the answers that you might find behind that might be, you know, pretty surprising. And I think for me, being in this administrative role, a lot of the things that I've learned because I've tried to put something in place because it's what made sense. But then I had that barrier and that red tape that's like, no, you can't do it that way because of this. So I think asking those questions, like as, you know, somebody who is in the healthcare system, like as a patient, and something seems odd, there's probably some type of like policy, legal, structural reason for why that actually occurred. And I would ask questions. Like, I think it's, you know, say like, you know, why did this weird thing happen? And I think you might be surprised by that answer. And so I think us and the back end admin role should probably also do a better job at explaining why certain systems are the way they are, because then I think it would demystify some of the questions that patients might have about why we do things in a certain way. So this has been really helpful for me too, just to say like, oh, I thought this was like something that folks might have already known. But now I'm realizing that that might not be the case. And so we could also do a better job at explaining this too. Yeah, I think this has been really insightful for me too, to just reflect on some of our systems. So thank you so much for the invite to be here today.
Thank you. Thank you.
Martina, any final kind of thoughts or anything?
No, I just, again, you know, thank you, Carmen, because again, you know, you know, like you just said, you're like, oh, these are things I thought people knew. And it's like, no, like this, you really just kind of opened up just like more ideas and things that I'm just thinking about. And I'm sure Lisette and I are going to touch base and like say, wow, like our mind was just blown about everything that we heard. But no, and I just, again, thank you for coming on, because I think a lot of people, as we've all stated, they're not always looking at the behind the scenes. They're just wondering, oh, well, why are you telling me this? Or, why can't the doctor do this? And knowing about how, nurses are treated and things like that, and even the education components. I think a lot of things people just didn't know. And so I just thank you for that insight. And now, like, I'm very curious to just, start like learning more myself. There's still a lot that I want to learn, a lot I want to do. So thank you for coming on and sharing your time with both of us, our listeners and our viewers. And I do believe people will get a lot out of this, out of both of these videos that you've done. So thank you so much.
And I'll just reiterate the things, Carmen. I think I hope those that are listening and watching just kind of learn some new things, because I know the Martina I have, as we mentioned. And I love sort of what you said, Carmen, of like ask questions, right? And sort of, how can we be better asking the questions? How can we sort of be curious as to these things? Because I think that brings transparency, that brings sort of, and it coming from the patient and coming from the community, will hopefully bring about and sort of force change if we start sort of like, we want that transparency and we want that. So appreciate you kind of just making that sort of a final focus, because I think it really is going to be we always say it's going to be a top and a bottom kind of way to meet at the middle to create that change. To those that are watching and listening, thank you again. Please, subscribe if you haven't, so you kind of get notified. We have plenty more episodes around this healthcare topic. I know that we are definitely gonna have Carmen back in the future for future episodes, because I think we only, I think, scrape the top layer with Carmen of some of these topics. So thank you all, and we will see you at the next episode. Bye, everyone.